Hello dear students and welcome to today's test and discussion in microbiology. I am Dr. Rohita, your faculty for microbiology in Medico. As you know, you guys have finished studying all the portions now and this is the time for your revision. So in the course of today's test and discussion, let us discuss some of the most high yielding areas from microbiology. Without wasting further time, let us start. So coming to the first question. A 40-year-old HIV positive male presents with a CD4 count of 150 cells per millimeter cube. He reports experiencing night sweats, unintentional weight loss, and a persistent cough. Radiology findings are given below. Which of the following infections is most likely responsible for his symptoms? And there is an X-ray and a CT image. And what are the options that are given? You've got tuberculosis, pneumocystis jirovecii pneumonia, cryptococcal meningitis, but I think it's actually cryptococcal pneumonia, and cytomegalovirus pneumonia. So one thing you must remember is it's an HIV positive male patient with a CD4 count of 150 cells per millimeter cube, and they have given that he has respiratory symptoms. Now, in almost 99% of the cases, when you get a question like this, the single most common entity that is responsible for causing pneumonia in an HIV positive patient is pneumocystis jirovecii. So whether or not you know about the other options, you would still be highly likely to be on the right answer if you pick pneumocystis jirovecii. Now here you can see that the X-ray shows some diffuse bilateral infiltrates, and the CT also to some extent shows some ground glassing. You can make out some ground glassing here. Here you can see the infiltrates also bilaterally. So the right answer here is also, like I said, it's pneumocystis jirovecii pneumonia. Now let us see. As per the CD4 count, you can categorize patients into different risk categories. If the count is more than 500, that means that generally the immune function is normal and there is less chance of opportunistic infection. The only opportunistic infection you can comment about is candidal vaginitis. Okay, whereas 200 to 499, when the count reaches that, it is again gives an increased chance of getting other opportunistic infections like TB. TB is already there in the question. Then some bacterial infections like pneumococcal infections, herpes zoster, and candidiasis, but this time it is oropharyngeal candidiasis. Then 50 to 200, that is less than 200 range, is where you get a lot of opportunistic infections, the most important being pneumocystis jirovecii pneumonia, cryptococcal meningitis, penicilliosis, toxoplasmosis, okay, cryptosporidiosis, progressive multifocal leukoencephalopathy, Kaposi sarcoma, histoplasmosis. So you can see that there are a wide variety of opportunistic infections here when it is in the range of 50 to 200. And try and remember pneumocystis jirovecii pneumonia, then cryptococcal meningitis, progressive multifocal leukoencephalopathy, Kaposi sarcoma, and some fungal infections like histoplasmosis, penicilliosis, and so on. Then it goes to less than 50. There are one or two very specific infections. One is non-Hodgkin's lymphoma, one is Mycobacterium avium complex, and then the CMV infections, mainly the CMV retinitis. Okay, so this is the classification based on the CD4 count. Now, when you look at this question, they have already said that the CD4 count is 150. That means it's less than 200. There's an increased risk of opportunistic infections. And here, pneumocystis jirovecii should be the first thing that comes to your mind. When you look at the clinical presentation, the patient is presenting with symptoms like night sweats, weight loss, okay, cough, all of them which are classically aligning with opportunistic infections. Now, radiologically, if you remember the X-rays, there were bilateral diffuse infiltrates on the X-ray. And like I said, there were ground glass opacities on the CT. Now, even if there is some confusion, you still need to know what are the other radiological that you can expect. So, if it's TB, it can be either a cavitation or an infiltration or an upper lobe consolidation. If it is CMV, they also can present with bilateral diffuse infiltrates, but fever and dyspnea would be the classical presentation. And for cryptococcal pneumonia, the opacities would be more nodular. Okay, so you would expect a nodular opacities for cryptococcal pneumonia. Now, a few more points about pneumocystis jirovecii. You know that it can exist as two forms, that is cysts and trophozoites, and the trophozoites is made up of 4 to 8 sporozoites. So the infective form here is the cyst form, that gets inhaled and goes on to become trophozoites in the lungs. Now, the pathology-wise, the alveoli is filled with a foamy vacuolated exudate. These words you should know. Foamy vacuolated exudate. That's why it's called interstitial plasma cell pneumonia. And in severe disease, you can see fibrosis, you can see so many changes, but you will never ever see ARDS. There will be fibrosis, there will be edema, hyaline membrane formation, all these things will be there, but ARDS is never seen in pneumocystis jirovecii pneumonia. Now, coming to the lab diagnosis, you can't diagnose this in sputum. You need either a BAL or a lung biopsy to diagnose it. And on GMS staining, you can see these black crushed ping pong balls against a green background. So remember the stain, that is gomori methenamine silver for pneumocystis jirovecii. You get black crushed ping pong ball like appearance. So remember this image, okay? These are the PCP, okay? Black crushed ping pong balls which are seen against a green background. Now this is non-cultivable, so you really can't do any culture there. Okay, you can do PCR for specific genes and you can do the beta-D-glucan in the serum. A beta-D-glucan in the serum would be a definitive pointer if you are suspecting a pneumocystis jirovecii infection. It is not only for pneumocystis jirovecii, but against the backdrop of a clinical suspicion, this test would be very useful. Now, treatment, the drug of choice is cotrimoxazole. Again, this is very, very important. And it has to be given for 21 days for HIV and for 2 weeks if the patient is a non-HIV. Okay. So, these are the important points about pneumocystis jirovecii. Infective form is the cyst. Okay. It can become the trophozoite form inside the lung. The staining method is gomori methenamine silver staining. Crushed ping pong balls appearance against a green background. It's a non-cultivable fungus. Beta-D-glucan may be used for diagnosis. Drug of choice is cotrimoxazole. And you can get a hyaline membrane disease but never an ARDS. Okay, and foamy vacuolated exudate is typical for pneumocystis jirovecii. It should be the first thing that comes to your mind whenever you see a question about a CD4 count less than 200 and an HIV positive patient. I hope this is very clear. Then coming to the second question. A 35-year-old man presents to the clinic with a circular rash on his thigh, accompanied by fatigue and mild fever. He recalls being bitten by a tick while hiking in a forested area. Which of the following is the most appropriate initial treatment for this condition? Is it doxycycline? Is it amoxicillin, ceftriaxone or azithromycin? So when you look at that rash, there's something very typical about that rash. Okay, when you see an image like this with a rash which is not a spreading type of rash, or it's not a maculopapular, a rash that is diffuse, but rather a very specific rash which is almost appearing like a bullseye. And together with this history in this patient with a tick bite, okay, and non-specific symptoms of fever, and there is a rash as well, the first thing that should come to your mind is a Lyme's disease. What is Lyme's disease? It's a disease which is caused by tick. What is a causative organism? It is Borrelia burgdorferi. So basically this question is asking you, what is the most appropriate initial treatment for a Borrelia burgdorferi caused Lyme disease? So here the answer is doxycycline. Okay, so let us have a look at a few points first about this. We already said it's caused by Borrelia burgdorferi, Lyme's disease, and the organism is an Ixodes tick, the causative. The vector is an Ixodes tick. It's a deer tick or a rodent tick as you call it, and this is the image of the tick. So you can try to remember, recall this image also. They can give a similar history and give the tick, and they can ask you what is the condition, okay? So the incubation period is usually under 1 month, okay? That is 3 to 32 days is the incubation period. And what you see there is a classic manifestation of Lyme's disease known as erythema migrans, which can be described as an annular bullseye rash or a maculopapular rash. So it's either an annular bullseye rash or a maculopapular rash, and that is erythema migrans, okay? This is mainly seen in the axilla, groin or thigh. This is seen in the early localized stage. So the first stage is known as the early localized stage. Here you get to see an erythema migrans, which is an annular bullseye rash in the groin, axilla or the thigh. So you can see how I have compared it with a bullseye. So bullseye is basically what you throw the darts on, okay? So very similar to that is the appearance of the rash. Now the next stage is the early disseminated infection, okay? That is the stage 2. So in this what happens is a disseminated. So there has to be hematological seeding that results in arthralgia, malaise and some neurological manifestations like meningitis. So there is some seeding happening that's causing arthralgia, malaise and meningitis, that is early disseminated. Late persistent is when it becomes, the arthralgia becomes Lyme arthritis. So the early localized is erythema migrans. Then the early disseminated is when there is dissemination resulting in arthralgia and some degree of meningitis as well can happen. And the late persistent infection is when the arthralgia becomes an arthritis, okay? Now coming to the treatment, the drug of choice is doxycycline. It's the drug of choice for adults and children above the age of 8 years, okay? And depending upon the condition, is it early localized or is it Lyme arthritis? Early localized means just 14 days of treatment would do. But if it's an arthritis, 1 to 2 months of treatment may be required with doxycycline. So in children under 8 years, what do you give? And for pregnant women, you can choose to give amoxicillin. Ceftriaxone is also used for CNS and CVS Lyme's disease, and that can be given for 14 to 28 days. And azithromycin is generally not preferred. So we've discussed all the antibiotics in the options. So doxy is the drug of choice, okay, for children and adults, children over 8 years and adults. Whereas for pregnant women and children under 8 years, you can give amoxicillin. For ceftriaxone can also be considered in case of Lyme, CNS and CVS Lyme's disease. Azithromycin is of no use, and depending upon whether it's early localized or a Lyme arthritis, or that's a late persistent one, you might have to consider modifying the duration of therapy, okay? So I hope that with this you have understood Lyme's disease, Borrelia burgdorferi, erythema migrans producing an annular bullseye rash, and the treatment of choice is doxycycline. Next question, which of the following statements about the genetic transfer capabilities of HFR strains during conjugation with F- cells is incorrect? Okay, I hope you've understood the question properly. So you have to pick the wrong statement here. HFR strains can transfer chromosomal genes along with the F plasmid to F- recipient cells. The duration of conjugation affects the number of chromosomal genes transferred from HFR to F- cells. F- cells receiving chromosomal genes from HFR strains become HFR themselves. Gene transfer from HFR strains to F- strains can result in recombination events in the recipient's genome. So in a single word, this is a question about conjugation. They are trying to see whether you know the process of conjugation in and out. That is what this question is about. So look at the options. HFR strains can transfer chromosomal genes along with the F plasmid to F- recipient cells. So the HFR strains have got an F plasmid. Along with that, can it transfer chromosomal genes? Yes, it can. The duration of conjugation affects the number of chromosomal genes transferred. Yes, that is also possible. F- cells receiving chromosomal genes from HFR strains do not become HFR themselves. So the option number 3 is incorrect. We'll discuss in detail. And gene transfer from HFR strains to F- strains could result in recombination events in the recipient's genome. That is also correct. So let us look at this. First, let's try to make an idea about the process of conjugation. So what is conjugation? Conjugation is basically the process of transfer of genetic elements from one bacterium to another through the agent of a sex pilus or a conjugation tube, and it's a method of horizontal gene transfer. So you have to imagine a physical tube, that is a conjugation tube or a sex pilus as it is called, that is acting as a channel for the transfer of genetic elements from one to the other. So the one that is transferring it is the male and the one that is receiving it is the female, and it was first discovered by Lederberg and Tatton. Okay. So there are basically three types of conjugation. One is the F plus and F minus mating. The other one is the HFR conjugation. And the third one is the F prime conjugation. If you know all these three, you will get the answer to this question. So what is F plus and F minus mating? This is very simple. You have got a donor and a recipient. The donor is the male and the recipient is the female. And how does one become male or female? The one which has the F plasmid that codes for the sex pilus is the male, and the one that does not have it is the female. So here there is the F plasmid, okay, that is coding for the pilus. You can see the pilus here, and the other one is the female. And the physical connection happens between the two, and the DNA polymerase that is present will cause the replication of the F plasmid and subsequent migration of that plasmid through the conjugation tube onto the other side. Ultimately, that pilus is broken and both the cells will become F plus because the plasmid has gone from here to here. So, this is also F plus, this is also F plus. Now, both of them look the same, right? So, there is no difference. So, I hope you guys have understood this very clearly. This is the F plus F minus mating, which you commonly call as conjugation. Now, there are some other types also. Next one is HFR conjugation. So what happens is you are seeing that the F factor is actually existing as a plasmid, but it can also exist as an episome, correct? So what is the difference between plasmid? Plasmid is extra chromosomal genetic element that's capable of autonomous replication, whereas episome is when that particular plasmid is integrated with the host cell DNA. So in such a case, that cell is called as an HFR cell. And when an F minus cell mates with an HFR cell, what happens? Let us see. So here you have the donor cell. This is an F plus cell. So the most important thing that you should remember is an HFR cell is an F plus cell in which the plasmid is integrated with as an episome with the host cell DNA. If you get that much, then you will not go wrong. So this is an F plus cell, and see, this is an HFR cell where the F plasmid has gone and integrated with the host chromosome. You can see it, right? And then when such a cell comes in contact with an F minus cell, what happens? There will be the formation of a pilus, okay? But an HFR cell does not have as sturdy a connection as a normal F plus cell has. And during the process of replication, what happens? The F plasmid will also start to replicate and it will start to migrate over into the other side. But before the entire process of replication actually gets completed, the pilus gets detached. So the entire F plasmid does not go into the recipient and only incomplete F plasmid goes. So unless the whole thing is there, it cannot become an F plus cell. So at the end of a conjugation between HFR cell and F minus cell, the recombinant cell which is formed again remains F minus. So when you started here, see, there was no green, okay? But once the HFR cell and the F minus cell will undergo a conjugation, the cell that is actually formed will be a recombinant cell. But in spite of being a recombinant cell also, it does not have the entire F plasmid, so it remains F minus. So HFR with F minus is recombinant F minus. Clear? Now coming to the F prime conjugation. So what is F prime? What happens when this HFR cell reverts back into the F plus cell? Some of the host chromosomal genes also go back with the episome. Go back and become the plasmid. So you have to imagine plasmid became episome. When episome became plasmid, it took some of the chromosomal genes also along with it. Okay. So here you can see that this is an HFR cell here. Okay, and then that will subsequently undergo a change and that will again become a plasmid only. And here you can see some blue. Okay, so in this image, actually speaking, I disagree with this red here. You need not show it like that because it can get confusing. So you must just think that there is a host chromosome, and once it gets separated, the plasmid also takes some part of the host chromosome along with it. Okay. So what happens when F prime conjugates with F minus? What do you get? Okay, let us see. So this is an F prime cell. Anybody has a doubt? No. Why? Because there is a chromosome and some of the chromosomal genes are present in the plasmid also. This is an F minus cell, no plasmid. So once the process of conjugation happens and the plasmid replicates and go to the other side, that plasmid will also carry the chromosomal components of the F prime cell. So subsequently what happens? Both the cells will become F prime. Okay. So when an F prime cell conjugates with an F minus cell, the resulting cell is F prime. When an HFR cell conjugates with an F minus cell, the resulting cell is recombinant F minus. When an F plus conjugates with an F minus, the resulting cell is F plus. Okay. Now you are not going to make this wrong, right? You all have understood it. So what is the role of conjugation? It's mainly for the transfer of resistance genes as well as for the transfer of call factors. Okay. So for all this you need conjugation. Now look at each option. HFR strains can transfer chromosomal genes along with F plasmid to F minus recipient cells. Definitely it can do. Okay. And because high frequency recombination, that is what is HFR, that can actually transfer chromosomal genes to the other side. That is the one that is responsible for genetic recombination. Then the duration of conjugation determines how many G chromosomal genes are transferred. Yes, the longer they stay in connection, the more the number of genes that can be transferred. Okay, so that's not any big thing that you can understand. F minus cells receiving chromosomal genes from HFR, they remain recombinant F minus. So this is false. Gene transfer from HFR strains to F minus cells can result in recombination. When you're giving a gene to the F minus cell, that can result in recombination. Remember the last image that I showed you? Yes, there can be recombination. Okay, so ultimately a new phenotypic trait can be expressed in the recipient. It's possible, isn't it? So this is about conjugation. Then the next question, a 55-year-old male with a history of COPD presents to the emergency department with sudden onset of high fever, chills, productive cough, with rusty colored sputum and difficulty breathing. On examination, he has decreased breath sounds and dullness to percussion on the right lower lobe of the chest. A gram stain of his sputum sample reveals gram-positive lancet-shaped or lanceolate-shaped diplococci. To confirm the presence of the polysaccharide capsule of the organism, which of the following laboratory tests should be performed? Okay, and they have given a gram stain here wherein you can see this gram-positive diplococci. Okay. So what have they said? They give a lot of information and then they become very specific towards the end. So they have said that there is a patient who has come with fever, chills, productive cough, rusty colored sputum, breathing difficulty, percussion also and auscultation also. You can make out that there is a definite consolidation there. Gram stain shows gram positive lanceolate shaped diplococci. Okay, that's it, another important pointer. And to look for the presence of the capsule, what you should do. And what are the options? Coagulase test, optokin sensitivity, Quell-Lung reaction or catalase test. So which organism are we looking at? Which is the organism that causes gram-positive lanceolate diplococci to be seen in gram stain? There's only one organism, that is Streptococcus pneumoniae. So catalase test is a test that is, catalase negative is all streptococci and enterococci, whether it is Streptococcus pneumoniae, viridans group, whether it is Agalactiae, that is the beta-lytic Streptococcus pyogenes, enterococci, all of them will be catalase negative. So catalase is not a specific test for strep, and of course it is not a test for the capsule. Coagulase test is a test that is used for staphylococci to differentiate Staphylococcus aureus from the coagulase negative staphylococci. So apparently it's not catalase, it's not coagulase. Optokin sensitivity. When do you use an optokin disc? That is used to differentiate Streptococcus pneumoniae from Streptococcus viridans. Both of them are alpha hemolytic. To differentiate between them, you need a optokin test. Whereas that is also not going to tell you anything about the capsule. So the Quell-Lung reaction, that is a capsular swelling reaction or the Quell-Lung or Neufeld reaction, is the one that is actually going to tell you about the capsule. Okay. Now, as I said, this is pneumococcal pneumonia. Okay, there is a rusty colored sputum that has been mentioned in the question. That's a very significant pointer towards pneumococcal pneumonia. And similarly, you can have red currant jelly sputum for Klebsiella pneumoniae. Gram stain, gram-positive lanceolate diplococci showing a halo. That halo is actually suggestive of the presence of capsule. Here you can see, what do you mean by a halo? Basically, immediately around the bacteria or immediately around the gram-positive diplococci, there is an unstained area. Then only you can see the pink area. I hope you can make out in this image here all of these. Okay, that is actually what is known as the halo. Okay, and that signifies the presence of a capsule. Then culture, yes, on blood agar you can find alpha hemolytic colonies. If you remember, there is alpha, beta and gamma hemolysis, and Streptococcus pneumoniae is alpha hemolytic. So you can see the greenish discoloration. Okay, this greenish kind of discoloration that you see is because of the partial hemolysis. Okay, whereas beta means what? It means complete hemolysis. Then biochemically what happens is there are a few tests that you will need like optokin, inulin, bile solubility. So optokin sensitive, inulin fermenting and bile soluble is Streptococcus pneumoniae. And that is how you get to differentiate it from the viridans group of streptococci. Both are alpha hemolytic. So here you can see that this is optokin sensitive, that is Streptococcus pneumoniae, and this is bile soluble, okay, and that is also Streptococcus pneumoniae. Then comes the capsular identification, that is the Quellen reaction, or like I said, the Neufeld reaction. It's a bedside test that was previously done directly on the sputum samples. What you do is that you take the sputum sample and you add a type-specific antiserum together with methylene blue dye. Then the capsule gets swollen, refractile and sharply delineated, and that is how you can make out the polysaccharide capsule. So see, before the addition of antiserum, there is no capsular swelling. But after the addition, you can make out that the capsule has swollen, okay, and it's sharply refractile and delineated. So this is a test that will help to demonstrate the polysaccharide capsule of Streptococcus pneumoniae. This was previously done, but currently it's more of latex agglutination testing with the type-specific antisera to know the serotype, okay. So like we already mentioned this, we've discussed this, coagulase test is for staph, which is coagulase positive versus the coagulase negative staphylococci. Optokin is not a confirmation and catalase is not going to tell you anything about the capsule. Then, the next question. A 38-year-old male wool sorter presents to the clinic with progressive difficulty in breathing, fever and malaise over the past 3 days. He reports exposure to untreated animal hides at his workplace. A number of pointers for this question. They have said that he is a wool sorter. He's got some symptoms like breathing difficulty, malaise and all that. And he gives a history of coming in contact with untreated animal hides. Apparently, he's got both the signs and the symptoms to suggest that he's got pneumonia. And here you've got a gram stain appearance that shows some gaps in the gram-positive bacilli. So what is the gap that you get to see? It's basically spores which are non-bulging. Okay, this is called the bamboo stick appearance on the gram stain. So which condition are we dealing with here? It's pulmonary anthrax. Okay, caused by Bacillus anthracis. So the simple straight question is, what is the initial antibiotic that you will give for anthrax? Is it penicillin, doxycycline, ciprofloxacin or vancomycin? So one thing about anthrax is that knowing it is gram positive, everybody tends to immediately jump and choose penicillin G. But for anthrax, the drug of choice is not penicillin G, it is ciprofloxacin. Okay, so that is the correct answer in this question. Let us see this a little bit more in detail. We've already discussed the clues, okay, and all those clues were there in the question. Now, what are the clinical features of pulmonary anthrax? Pulmonary anthrax is otherwise known as wool sorter's disease, whereas the other form of anthrax is cutaneous anthrax, which is known as hide porter's disease, yes. So, wool sorters and those individuals who handle animal hide, fur, all those things are more prone to get this condition. It's an inhalational anthrax. So basically, how does it come? You inhale the spores, whereas the other one, it was due to traumatic inoculation of spores, that is hide porter's disease, wherein they were carrying the hide on their back and that is how they would get the condition. So clinical presentation, remember only these two words, it is hemorrhagic pneumonia. It can present as a hemorrhagic pneumonia. The other one used to present as a black eschar. You remember that? Okay. Then imaging wise, if you look at a chest x-ray, you can see mediastinal widening and pleural effusion. So here you can make out this mediastinal widening. I hope you can see these black arrows here. The mediastinum has become widened. Okay, you can't make out much of a pleural effusion here, but in very advanced cases, you won't see the mediastinal widening, but there will be a large pleural effusion. So that should suggest advanced pulmonary involvement. Now coming to the lab diagnosis, gram stain we already said is a bamboo stick appearance. These are the non-bulging spores. So which gram-positive organism produces bulging spores? It is Clostridium. Okay, these are the non-bulging spores. Then on nutrient agar, if you examine the plate under a microscope, you get to see something called as a medusa head appearance. On blood agar, there are non-hemolytic colonies will be formed on blood agar. On gelatin stab, you get an inverted fir tree appearance wherein the liquefaction is maximum on the top. So here the liquefaction will be much more than down below, that is inverted fir tree appearance. Then when you culture it on a media which contains, solid media which contains penicillin, you get what is known as a string of pearls appearance. And also it shows a positive Mecfidine reaction. Mecfidine reaction is because of the presence of a capsule, okay. And what is the type of capsule for Bacillus? It's not polysaccharide, rather it is polypeptide, okay. So it's a polypeptide capsule that you get to see. Okay, and see this is a classic image showing the Mecfidine reaction. So it's very, very important with the diagnosis with respect to the diagnosis of Bacillus anthracis. Then there are different media. The selective media is called as PLET. Then there is a ring precipitation test called as Ascoli's thermoprecipitant test, which is again for Bacillus anthracis. You don't have to get into the details of that. Because there is a spore, you can use an Ashby spore method to demonstrate the spore. You can see the greenish spore and the reddish bacilli in this. Okay, the spore is green and the bacilli is red. And modified AFP smear using 0.25 to 0.5% of sulfuric acid can also be used to demonstrate the spore. So like I said, there are numerous named, lab diagnosis tests for this. Try to go back and recollect what happens on gram stain. You get to see a bamboo stick appearance. Then on nutrient agar, you get a medusa head appearance. On blood agar, it's non-hemolytic. Okay, gelatin stab is inverted fir tree. Then solid media with penicillin, there will be something called as a string of pearls appearance. Positive Mecfidine reaction demonstrating the capsule, that is a polypeptide capsule using polychrome methylene blue. Selective medium is PLET. There's Ascoli's thermoprecipitant test. You can use the Ashby spore method or the modified AFP for the spore. Now, when it comes to the management, there is the induction therapy and the maintenance therapy. So, induction therapy consists of ciprofloxacin with meropenem and linezolid for 2 weeks. And that is if it is meningitis. Whereas for non-meningitis, it is ciprofloxacin with either clindamycin or linezolid for 2 weeks. So, ciprofloxacin is there only. It's meropenem with linezolid for meningitis, whereas it is clindamycin or linezolid if it is somewhere else, but both are for 2 weeks. And maintenance therapy, you can continue it with ciprofloxacin or you can give doxycycline for 60 days. And anthrax, so raxibasumab and obiltoxazimab, these are the two monoclonal antibodies that are used to neutralize the anthrax toxin. So anthrax, raxibasumab and obiltoxazimab. So these are the two ones. Okay, remember their names because they're relatively important, okay, for neutralizing anthrax toxin. The next question is, a 30-year-old man presents to the emergency department with symptoms of meningitis, including headache, fever, neck stiffness, and altered mental status. The cerebrospinal fluid analysis reveals gram-positive organisms. To differentiate between Streptococcus pneumoniae and Listeria monocytogenes, a CAMP test was performed. Which of the following results is most consistent with a positive CAMP test for Listeria monocytogenes? So this is a 30-year-old man who has come with features suggestive of meningitis. Both pneumococci and Listeria can cause meningitis. And you can just make out that it is gram-positive. Apparently, they were not good enough in saying whether it was a gram-positive cocci or a gram-positive bacilli, right? So they went and did a camp. So what will be the camp of Listeria? That is the question. No hemolysis in the presence of Staph aureus. Enhanced hemolysis forming an arrowhead pointing towards Staph aureus. Enhanced hemolysis forming an arrowhead pointing away from Staph aureus. Complete inhibition of hemolysis in the presence of Staph aureus. So what is the interpretation of the CAMP test for Listeria? That is the question. So the right answer is that everybody knows that group B strep gives a CAMP test positive with an enhanced hemolysis with the arrowhead pointing towards Staph aureus. But it is not specific for group B strep alone. There are many other organisms which give a very similar CAMP. And one such example is Listeria. So the correct answer is enhanced hemolysis forming an arrowhead pointing towards Staph aureus. Let's look a little bit in detail into the CAMP. What is CAMP actually? It's Kristen Atkins Munch Peterson. Okay, so that is a CAMP test. And it's mainly used for strep agalactiae or group B strep, which has got the CAMP factor. So when on a blood agar plate which is streaked with Staphylococcus aureus that contains the sphingomyelinase, okay, that is the beta-lysine sphingomyelinase when it is streaked, then when the CAMP factor is also released by this group B strep, together there will be an enhanced zone of hemolysis. So there is a sphingomyelinase for the staph, there is a CAMP factor for the group B strep, and together there will be an enhanced zone. But the other organisms that test positive for CAMP besides group B strep is Listeria, Rhodococcus, Pastorella and Aeromonas. So remember that Aeromonas, Listeria, Rhodococcus and Pastorella also give CAMP positive. Then there is something called as a reverse CAMP, okay? And the reverse CAMP test, the Clostridium perfringens, which has got the phospholipase D or C. When that comes in the presence of sphingomyelinase, what actually happens is that the arrowhead of the hemolysis will be pointing away from the Staph aureus streak. So for Listeria and for Rhodococcus, it's pointing towards the Staph aureus. That is mainly because of the CAMP factor. Whereas a phospholipase C will not allow that hemolysis to point towards the Staph aureus. Rather, the hemolysin or the sphingomyelinase of Staph is stopped by the phospholipase C or D in the Clostridium perfringens. So that is why the arrowhead is pointing away from it. This also is not unique to Clostridium perfringens. There are other organisms like Ercanobacterium hemolyticum and Corynebacterium ulcerans and Pseudotuberculosis, which are also reverse CAMP positive. So here you can see this is the Staph aureus. Streptococcus agalactiae, there is a arrowhead that is pointing towards the Staph aureus. Here you can see this. Listeria also, there is an arrowhead that's pointing towards the Staph aureus. Whereas for Ercanobacterium hemolyticum and Clostridium perfringens, here you can see that this is the arrowhead. This is actually pointing away from the Staph aureus. Okay. The next question, a 32-year-old female presents to the outpatient clinic with a 10-day history of gradually increasing high-grade fever, persistent headache, malaise and abdominal pain following travel to Kolkata. On examination, she is febrile with a temperature of 39 degrees centigrade or 102.2 degree Fahrenheit, shows mild hepatosplenomegaly and has multiple rose-colored spots on her abdomen. Lab investigations reveal the following. The Vidal test result is O antibody titer 1 in 160 and H 1 in 80. Which one of the following findings is most consistent with an infection in this patient? So everything is actually given in the question, even the diagnosis also you can make out. The patient has a 10-day history of fever, persistent headache, abdominal pain, okay, after traveling to a place which is endemic for some condition. She is febrile, she's got hepatosplenomegaly and she's got rose-colored spots. And she has a Vidal titer also. So what are we looking at? We're looking at Salmonella typhi. That much is clear. Now, which of the following findings is most consistent with an active infection in this patient? Is it a high neutrophil count with toxic granulation, relative bradycardia, hypersegmented neutrophils on peripheral smear, or the presence of eosinophilia? So the classical finding that we get to see in a patient with Salmonella typhi is not eosinophilia, is not hypersegmented neutrophils, or it's not a high neutrophil count with toxic granulation, it is relative bradycardia, right? So relative bradycardia is that specific sign for Salmonella typhi. Now, what are we already discussed the first part, why it is so, okay? Now comes the clinical features, okay? So the pattern of the fever is gradual onset and then it goes on to become sustained high-grade fever. What do you call that type of fever that you get to see in typhoid? It's called stepladder pyrexia. Then rose spots are basically macular or petechial rash seen in the abdomen, okay, and sometimes on the chest and so. So these rose spots, which is another classical finding of Salmonella typhi. Then of enteric fever, then hepatosplenomegaly is also seen. So if you look at the clinical features, an incubation period of 10 to 14 days will be there, and usually in the first week the patient develops stepladder pyrexia, abdominal pain, constipation, some degree of malaise, headache, and relative bradycardia. So headache, malaise, constipation, stepladder pyrexia, relative bradycardia, all this are pointers towards typhoid. And by the end of the first week, what happens is that there will be the appearance of rose spots, there will be diarrhea and some degree of splenomegaly and abdominal distension will be there. Okay. In the second week, these symptoms will slowly progress, and by the end of the second week, the patient can go into delirium, coma, and even death. This delirium is called muttering delirium or typhoid vigil, and there will be presence of typhoid ulcers in the intestine which can undergo perforation or even bleeding. Okay, and in general, when you look, all the counts will be found to be decreased. So the presence of fever, leukopenia, hepatosplenomegaly, and longitudinal ulcers in the intestine, these are characteristic findings of typhoid or enteric fever. So you've got leukopenia, thrombocytopenia, elevated liver enzymes but mild elevation of AST and ALT. Okay. Then comes the Vidal test. It's a serological test that's used for the diagnosis of enteric fever. Elevated O and H antibody titers can be seen, more than 1 in 100 and more than 1 in 200. So here it is more than 1 in 160 and H is 1 in 80. Okay. So rather than showing a single titer increase, it's always better to go for a 4-fold rise in titer at an interval of 1 week in paired sera. That will be more meaningful. There can be false positive in case of anamnestic, that is some unrelated fever that's resulting in an increase in the titer. So that can be there. False negative could be when you're doing the test too early or too late in the infection, or because of the presence of prozone phenomena, that means excess of antibody. Okay. Now, you remember that when you do a lab investigation for typhoid, the code dictum was BASU, right? So, in the first week, you will do a blood culture. In the second week, you will do a Vidal. And in the end of the second week to third week and all that, you will do a stool and a urine culture, okay? So, how will you interpret the results of a Vidal test? If it's rise of TO and TH, that means it is the Salmonella typhi. If it's rise in TO and AH, then it is Salmonella paratyphi A. TO and BH, then it's Salmonella paratyphi B. If only O has risen, that means that it is a very recent infection. This I want you to remember. O antigens are, O antibodies are IgM antibodies and H antibodies are IgG antibodies. So how do I remember this? It's medical officer, government, hospital. Okay, so medical officer means IgM is the one that is O and IgG is the one that is H. Okay, so when only O has risen, it means it's recent infection. When it's only H, it could be the patient is convalescing or there has been a past infection, or it could be anamnestic. It could be anything. Then only there is no O, but only TH, AH and BH have elevated, then it's a post-TAB vaccination. Okay. So relative bradycardia, we said it is a lower than expected heart rate for the typhoid fever. It's characteristic of this condition. It's otherwise known as faggot sign. The next question, a 3-year-old child is brought to the emergency department with high-grade fever, irritability and neck stiffness for the past 2 days. A lumbar puncture has been performed and the CSF reveals gram-negative cocobacilli. The CSF culture is incubated on chocolate agar, and after overnight incubation, small colonies are observed surrounding the Staphylococcus aureus streaks. Which organism is most likely responsible for this infection? Is it Neisseria meningitidis, Streptococcus pneumoniae, Haemophilus influenzae, or E. coli? So even if you don't know anything about this question, just by looking at the gram-negative Coccobacilli, you can say that it's not Neisseria meningitidis, it is not Streptococcus pneumoniae, and it's not E. coli. Okay, but there are other pointers to suggest why the answer should be Haemophilus influenzae. It is gram-negative Coccobacilli incubated on chocolate agar, producing small colonies around Staphylococcus aureus streaks. Would you call that? It is called satellitism. Okay, so you can see satellitism, and all these are pointers towards H. influenzae. So the clinical presentation, like we know, suggests bacterial meningitis in a young child. Now the incidence of Haemophilus influenzae meningitis has greatly decreased because of the presence of vaccination. The most important virulence factor for H. influenzae is the capsular polysaccharide. Mainly H. influenza type B is the most virulent one, but there are types A to type F. And what are the key laboratory findings that help you to support this? One is gram-negative Coccobacilli. Yes, in gram stain, you can see them as small gram-negative Coccobacilli. Then on chocolate agar, Haemophilus influenzae is a little fastidious. It requires factor X and factor V for growth. Okay, so factor X is hemin and factor V is NAD. So these factors are required for growth. Okay. Then what about satellitism? Satellitism is when you get to see small colonies of H. influenzae surrounding the Staph aureus streak. Okay, so let me show you this image here. See, now this is from a real culture plate. This is the Staph aureus, this thick one that you get to see here. This full thing is a Staph aureus here. And can you appreciate the small tiny colonies that are growing on either side? See here and here. These are actually the H. influenzae. So what is the reason for this H. influenzae growing on either side of Staph aureus streaks? We know it requires NAD plus, and NAD plus is released by Staph aureus. So that is one reason why they say that it grows there. Another one reason that they say is that the staph releases beta lysine, which causes lysis of RBC. And inside the RBC, you have got this NAD, that is NAD factor is also there inside the RBC. So whatever be the reason, it is because of the presence of NAD plus that you are able to see this. Okay, NAD plus released by Staph aureus as well as RBCs. Then, which of the following is the correct sequence of reagents used in gram staining? Is it crystal violet, alcohol, iodine and safranin? Crystal violet, iodine, alcohol and safranin? Is it safranin, crystal violet, alcohol and iodine? Iodine, crystal violet, alcohol and safranin. So this is a very simple, straight question, the sort of questions which nobody should make it wrong, because this is going to be a huge loss for you if you don't know this. So for gram staining, the normal series of steps is crystal violet first, then iodine, then alcohol, then safranin. That means it is option B. Okay. So what is crystal violet? It's a primary dye. What does it do? It goes and gets attached to the peptidoglycan layer. Then iodine acts mainly as a mordant. Okay. It will go and bind to the crystal violet and forms a crystal violet iodine complex. Okay. And that actually binds the crystal violet more strongly to the peptidoglycan layer. It's a mordant. You have a decolorizer or an organic solvent, which is usually an alcohol or acetone, and that will bring about decolorization. And finally, there is a counter stain that can be dilute carbol fusion or safranin. And if the primary stain is gone, then the counter stain will be taken up. Okay. So this is what happens. You apply crystal violet, then you apply the iodine, which is a mordant. After that, you use an alcohol and decolorize it, and you apply the safranin. So if it's gram negative, it will become pink. If it's gram positive, it will remain purple. Why do gram negative organisms get decolorized that easily? There are many reasons for that. Everyone knows that the peptidoglycan layer is not as thick as in gram positive, and it's less permeable. Okay, I mean it's more permeable. Okay, so it will allow the dye to run out of it very easily. That one point is known to all, but that's not the only reason. The protoplasm is actually less acidic for gram negative. So what happens is that the basic dye will not be retained as well as in gram positives. And the gram negative has got a lipopolysaccharide layer which is easily digested by the organic solvent. So that gets completely destroyed, allowing whatever dye is inside to run off outside. So these are the three reasons: less acidic protoplasm, presence of lipopolysaccharide, and a thinner peptidoglycan layer with fewer cross-linkings, making it more permeable. Then comes the 10th question. A 34-year-old male presents to the dermatology clinic with a painless ulcer on his penis, which developed 2 weeks after unprotected sexual intercourse. He also reports generalized lymphadenopathy. A clinical diagnosis of primary syphilis is considered. Which of the following tests is more specific for diagnosing an infection with Treponema pallidum? Is it RPR, VDRL, FTA-ABS, or dark field microscopy? So the diagnosis, as you know, has already been made out. That is, it is a primary syphilis case. It's a male with a history of unprotected sexual intercourse, now presenting with a painless ulcer and generalized lymphadenopathy. So the chancre is there. How do you diagnose the test? So all these tests can be used, but which is the diagnostic one? Rapid plasma reagent and VDRL are tests which are non-treponemal tests using a non-specific antigen to diagnose the presence of Treponema pallidum. So that cannot be considered to be the most specific test for diagnosing. Direct fluorescent dark field microscopy can actually be used, but it is something which is, if you get it, it will be great, but the chances of missing out is too high. So the test which is most sensitive, most specific for all stages of syphilis is FTA-ABS. So syphilis is caused by Treponema pallidum, and there are different types of serological tests. There is a non-treponemal test and a treponemal test. The non-treponemal test is basically making use of a cardiolipin antigen to detect non-specific reagent antibody. So the reagent antibody is an IgG antibody, and the antigen is actually a cardiolipin antigen. It's used mainly to monitor treatment response rather than for diagnosis, and there is a possibility of biological false positives with non-treponemal tests. So among the non-treponemal tests, I think you are most familiar with VDRL and RPR. So VDRL is a microscopic test, but RDR is macroscopic. Both are slide flocculation tests. VDRL can be done in the CSF also as well as blood, whereas RPR can only be done in the blood. So that was with cardiolipin antigen reagent antibody. Now we are using specific Treponema pallidum antigen, both IgG and IgM. There it was only IgG. And you can detect species-specific antibodies. So what are the tests? You've got TPI, that is Treponema pallidum immobilization assays, FTA-ABS, TPHA, TPPA, like that there are different tests. Now FTA-ABS is the first serological test to become positive after infection, highly sensitive and specific for all stages of syphilis. IgM, FTA-ABS can be used to diagnose congenital syphilis as well. So it's one of those best tests for syphilis. Another test which is highly specific and highly sensitive is a Treponema pallidum particulate assay. So TPPA is also highly specific and sensitive. So non-treponemal test is VDRL and RPR, and treponemal test is FTA-ABS, TPI, TPHA and TPPA. Then there are some direct detection methods like dark field microscopy. So what do you get to see? You can visualize the live spirochetes, okay, can be seen from the lesion exudate. They'll be slender, spirally coiled and having the typical corkscrew motility. The specificity is high when the spirochetes are observed, but you need a considerable degree of expertise, so you cannot rely on this test. Then there are also other tests like direct fluorescent antibody staining, that is DFA-TP, that is to be performed on the smears which are prepared from fresh clinical samples. So whenever you get a test like direct fluorescent antibody testing, that is the test that you have to pick because it's very sensitive and specific if you are able to do it. Then another problem with Treponema pallidum is that they are very slender. So you want to increase its thickness by doing silver impregnation. And there are silver impregnation methods for tissue sections, and Fontana's and Levadity staining can be done after silver impregnation to enhance the visualization of spirochetes. So we have a range of tests, but when it comes to a serological test, it's always FTA-ABS more than TPPA. VDRL RPR is mainly for response to treatment, and there is a possibility of biological false positive. The non-treponemal test detect IgG antibodies, but the treponemal test detect IgG and IgM antibodies. Dark ground microscopy, direct fluorescent antibody testing, and silver impregnation are methods for direct detection, but normally they require some more expertise, and DFA-TP is actually an excellent test which can be used for the diagnosis of Treponema pallidum infections. Okay, so I think now we can take a short break and then we can be back. So now coming to the next question. A patient presents with chronic diarrhea, abdominal cramping and nausea. Stool examination reveals cysts. What is the first line treatment for this infection? Okay, and an image has been given below. So I have a few points in this question with which I cannot agree. The first thing is that they have said the stool examination reveals cysts. But I feel, and I'm sure you also agree, that what they're showing is not a cyst. It's actually the trophozoite, right? So the stool examination, ideally the question should be stool examination reveals trophozoites, because for this organism it is easier to make out the trophozoites than the cyst. So I think that there should be a correction here and it should be trophozoites. Okay. And what is the first line treatment here? And what you notice unique to this, there is a pear-shaped, a tennis racket-shaped trophozoite that you can see in the stool examination. And is it metronidazole, tinidazole, nitazoxanide, or praziquantel? So if you can make out the shape, then you know that there is only one organism that appears like this. That is Giardia. Okay, and for Giardia, both the answers, that is metronidazole and tinidazole, are correct. Now I'll tell you why during the course of the discussion. So the image depicts an iron wet mount demonstrating cysts. No, I don't agree with it. I think it's a saline or an whatever mount it may be, but it's the trophozoites here that you're able to see. Okay, so it shows a wet mount that demonstrates trophozoites of Giardia intestinalis, which is also known as Giardia lamblia or Giardia duodenalis. So it's an intestinal flagellate that commonly presents with diarrheal symptoms. It can cause both epidemic and endemic intestinal disease and diarrhea. And it's the most common parasite that does that. So an epidemic or endemic intestinal disease with diarrhea is most commonly due to Giardia. And Giardia is common in the tropics and subtropics, and it's mainly seen in the duodenum and the upper jejunum. So there are two forms, that is the trophozoite form and the tetranucleate or the oval cyst. Okay. So first coming to the trophozoite form, it is the replicating, feeding, pathogenic form, which is pear-shaped. It is flagellated. Okay. It is found in patients with active disease. It's got 4 pairs of flagella, 2 axostyles and 2 nuclei. So here you can see the nuclei. Okay, I can probably show you. Here you can see the nuclei. Okay, and there are the flagella also. You can see the 4 pairs of flagella as well here. So it's got 4 pairs of flagella, 2 nuclei and 2 axostyles, and it's pear-shaped or tennis racket shaped, and it's usually indicative of active disease. Whereas the tetranucleate or the oval cyst is the infective form, it's the diagnostic form, it's found in the feces of carriers and patients with active disease. So it's found in the feces of carriers and patients, okay, with the active disease. So mode of infection here is fecal-oral. So remember this, there's trophozoite and there is cyst. So trophozoite is the feeding form or the replicating form, which is also seen in patients with active disease. Whereas the cysts are actually the infective form and the diagnostic form. So the cysts should be, and the cysts are the ones that are commonly seen in carriers or as well as in the patients. So either this question should have been cysts are seen and an image, the cyst should have been there, or this question should have been trophozoites are seen and the image should be supporting the trophozoites. So here both of them are mutually contradictory, but from that image what we are seeing is the trophozoite. Okay, so that is the reason why we're carrying this discussion forward in that line. The mode of infection is feco-oral, and clinical features wise the most common is an asymptomatic infection, but it can also present with malabsorption, malnutrition, bloating, belching, diarrhea. So they can be symptomatic, but the most commonly you get to see is just asymptomatic carriers. And for lab diagnosis, you need at least 3 stool examinations because trophozoites are intermittently shed. They tend to be adherent to the duodenal mucosa. And they've got the classical tennis racket shape or the pear shape and a falling leaf sort of a motility also. No RBCs will be seen on stool microscopy, unlike for Entamoeba histolytica. You can do a duodenal aspirate sampling for an endro test. You can also do a histopathological examination. ELISA and immunochromatographic test for the stool antigen antibody, all those are available. And culture can be done on Diamond's media. There could be molecular diagnosis as well. So in general, all parasitic infections follow this pattern. You have a microscopy, and if you can do a culture, then you speak something about the culture. If not, then there could be serology, both antigen and antibody, and molecular testing is also there. And treatment consists of tinidazole, metronidazole, nitazoxanide. So all these 3 options were there in the question. But in general, for trophozoite forms, it is metronidazole or tinidazole that is very effective. And so that is the reason why I've chosen either one of these answers and I've left out the nitazoxanide part. And another thing is, it's very hard to pick between these two, right from CDC to WHO to the standard books. Everywhere it's mentioned tinidazole or metronidazole. There is never an advantage of one over the other. If you choose tinidazole, you could be more right in a certain way that only a single dose is required. It's easier to give. Metronidazole has to be given over a few days. But other than that, there is no definitive, advantage or a pointer that says that one is better than the other. That is the reason why I think both the options are correct. Okay. So Giardia, Lamblia, duodenalis and intestinalis are one and the same. The infective form is the cyst and the diagnostic form is also the cyst. Trophozoites also can be made out because of its pear shape and its falling leaf motility, its tennis racket sort of a shape as well that it has, with 2 nuclei, 2 axostrials and 4 pairs of flagella. It's a fecal organism that normally presents as asymptomatic but can have a range of symptoms as well. And treatment, diagnosis wise, we've already discussed the diagnosis, and treatment is mainly either tinidazole, metronidazole or nitazoxanide. Okay. So we'll take a short break after this and then we'll get back.